So I call this talk a call to action, and I'm very passionate about children's mental health. And I really do feel that children's mental health is key to our overall child's health. I am a child psychiatrist. Sometimes we do get some flack. I think that sometimes rightly, but mostly I think hopefully just through not people understanding our role. I actually spend more time taking children off medications than putting them on medications. But I really think that we are unfortunately mislabeled. We should have been called family psychiatrists because, again, the way to help a young person in their life is actually to motivate, engage everybody around the child. That's how you really help. And it's actually how you help adults as well. But it is, again, more of my focus that young people come to me than adults. So I'm going to talk to you today about an initiative that the NAMI organization in Texas helped make this happen. So you really have to, when we speak of Deanna and others, this is a collective action that Texas took in the 2019 legislative cycle that really required so many team members to really push it through. So when I talk about what I'm talking about today, know that I think some pride with NAMI being one of the team members that really helped make this legislation become a reality. As a psychiatrist, I generally don't have any conflicts of interest related to financial. I'm riddled with other kinds of conflicts, but they're mostly, psychic and emotional. And I do get my mental health checked regularly. But I also want to thank Dr. Noon Tran, who is a developmental pediatrician and is our pediatric consultant for Cpan, which is the Texas Child Psychiatry Access Network. That's the first acronym you're going to hear me say. And then also I would like to thank Luann Southern, the executive director for the consortium. So some of the slides you're going to see today are slides that are from Dr. Tran and from Luann. So this is the slide that if you go to our website, you will see kind of one of the first things. And here you can see our vision for the Texas Child Mental Health Care Consortium is ambitious but accurate. We like to think big in Texas, of course. All Texas children and adolescents will have the best mental health outcomes possible. And that really is something that I believe with all of my heart. And I also believe that it's a family-centric, patient-centric process. It's not for me as a doctor to tell you what's your best health. It's me as a doctor to come and partner with your family and determine together what's the right direction moving forward. And so this is a vision that the consortium has for ourselves. And this was created by Senate Bill 11 in the 86 legislation. And again, the goal of this consortium is to leverage, and here's another acronym for you, HRIs, health-related institutions of higher education, to improve mental health care for children and adolescents. So this is a statewide initiative across our big state. We're going to do all these things across the place. So obviously you're going to have some of that work up in North Texas, but it's everywhere throughout the state of Texas. I'm going to tell you about the 5 initiatives that are involved within the Texas Child Mental Health Care Consortium, but some of them I'm just going to talk to you about briefly, and then I'm going to spend most of my time talking about the Cpan network as well as the second one, the TCHAT, Texas Child Health Access Through Telemedicine. Again, another lovely acronym. But I will briefly run through the other ones just so you're aware of all the initiatives within the Child Mental Health Care Consortium. So the first one that I'm not going to spend too much time on this slide because we're going to spend a lot of time later talking about it is the Child Psychiatry Access Network. And as you can see here, the HRIs, health-related institutions of across Texas, are all involved with having a region of Texas in which they are going to collaborate and coordinate with primary care physicians to provide educational consultation to primary care physicians who are treating young people that have mild to moderate mental health disorders that can be safely treated within a pediatric or family practice location. So that's one of the initiatives that we're going to be speaking on, and I will talk about that in much greater detail. The other one, again, is the Texas Child Access Through Telemedicine, or TCHAT. And this is direct telehealth into schools with the pandemic, with families being remote. Like, for example, in our Houston region, about 50%, 60% of families are remote, 40% are in person. So we had to shift very quickly with COVID. Fortunately, telehealth was able to do that. So we are doing care that is both in families' homes, as well as care at the school campuses when kids are at school. So the goal of this is to provide care for youth who are having an urgent mental health issue that they need help more immediately, and they can get this service through school districts across the Texas. And again, I will spend more time talking about that today as well. The other initiative within the consortium is called the Community Psychiatry Workforce Expansion. And what this initiative is about is helping, as a training director for child and adolescent psychiatrists, one of the things I want to do is have my physicians be very well trained, obviously. And the best way to do that is actually to expose them to working in a number of different learning environments, different systems of care. And local mental health authorities are a key resource for youth and families in Texas. But a lot of times they struggle to have mental health trainees on their in their organizations financially. So the state is now providing some support so we can add residents and child psychiatry fellows into LMHAs across Texas, have them have a high quality educational experience, provide some additional services for youth and families because of those additional people power, and then hopefully they will have such a good experience for that. Once they graduate from a program like Baylor, they may choose to work in an LMHA afterwards because there is a chronic shortage of physicians in Texas as it relates to child and adolescent psychiatry. So we already have started this off, and beginning in this July of 2020, we had 20 additional psychiatry residents and fellows work across a number of LMHAs in Texas. And additionally, we had additional faculty members who are working with those fellows to teach them what's the best way to really be a good, well-rounded child psychiatrist for families. The other workforce initiative is actually aimed specifically at child psychiatry and increasing the number of child psychiatrists trained in the state of Texas. One of the things that you may or may not know about child psychiatry is that it is a sort of a long and arduous process to become a child psychiatrist. First, I need to do undergraduate, then I need to go to medical school, and then I spend anywhere from 5 to 6 years in my postgraduate training before I become a child psychiatrist. So there is a long process that it takes to train us up well, and there's not enough programs out there in Texas. So what this additional initiative has done is allowed for programs to either start new programs from scratch, and several of them are doing that across Texas, or as programs such as Baylor, who we've had a child fellowship now for, oh my goodness, at least 40 years, that we are able to expand and increase the number of fellows that we're training every year. And the other thing that we know about training is that because for most physicians, this is the last bit of training that they do before they're free and go out into practice, is that they often will stay put with that wherever they did their last training. So we're really thinking it's smart for Texas to help us pay for their fellowship, because then there's a really high chance that they'll stay in Texas and to continue to serve Texas children and families. So these are the 4 initiatives that were developed within this SB 11 bill. And along with that, there was some additional dollars for research, and I'm not going to speak about the research necessarily today, but you can certainly go to the website, as you can see right here, and look up about some of these initiatives. This website is also under development, and we will see an improved website within the spring as the sort of IT and tech people, who I am not an IT tech person, they are working on developing. And so I would definitely say make this a favorite and periodically check back, because we will have new initiatives and new information for youth, family, primary care physicians, anybody who's interested in what's going on with the consortium. So actually what I'm going to spend most of my time talking about today is these 2 specific programs that are more direct care services that are called the Cpan and TChat. And I'm going to start off by actually discussing with you, which you probably know, but to me it's very important and bears repeating, what is the percentage of youth with mental health disorders? And then I'm actually going to talk to you about the allocation of child psychiatrists in Texas. I think I kind of gave it away with that other slide, but we'll look at it again. And then I'm actually going to review with you what the American Academy of Pediatrics actually recommends when it comes to pediatricians managing mental health. We're then going to discuss some other statewide collaborative care models that we have modeled CPAN after. And then I will move into talking about our specific network here in Texas and how it will help children and families. And then finally, I'll give you some updates and information about the TCHAP program and its process in standing up across the state of Texas. So those are the things I'm going to discuss. And then when I get done, I'll be very much happy and available to answer any questions. So again, this is something you probably know, but I really feel like it bears some repeating. 1 in 5 children will have a mental health illness, but we know that of those children, upwards to 30 to 40% of them do not get a treatment. We know that mental health or mental illness affects all aspects of our life. And so as you can see, the mental health is raining down on the other aspects of kids' lives that can affect their physical health. Eventually they affect their education, which then can move forward to affect their employment, and obviously affects and impacts relationships. We know that 90% of those youth who end up unfortunately committing suicide are found to have a diagnosable and treatable mental health disorder. And if only they had been able to get access to treatment at an earlier time point in their illness, maybe we would have been able to prevent them having suicide. And we know that depression and anxiety are the most common mental health illnesses, and there are plenty of evidence-based approaches that include psychosocial treatments and not just medical management treatments that can be very effective for managing these disorders and helping people live full and healthy lives. But we need to be able to get that care out to them, and we need to not wait until it's at its most severe. And the reason why I say wait, not wait, is that we have now, unfortunately, a trend in the last several years with suicide, and this is separate from COVID. We don't know exactly what COVID is doing. There is certainly concerns, but we don't have the data just yet related to COVID. But we do have the unfortunate news that for the last several years, the suicide rate among youth has been rising, and it's going in the wrong direction. And it is now the second leading cause of death for youth in America. So I'm just going to give you a few facts. I know this slide says it, but I'm going to say a few more. There is approximately across the United States about 20,000 people who lose their lives via homicide. When you look at suicide, it's actually about 50,000 people who lose their lives because of suicide. So the rate of suicide is 2.5 times greater than the rate of homicide. And yet when you think about how many resources, appropriate resources, I'm not trying to say take away resources, but how many resources we do when it relates to homicide, and then you can kind of see what we're not doing when it relates to suicide, you can clearly understand that this, in my opinion, is about the stigma around mental health and the feeling that people don't want to talk about it. One of my compatriots at the Meadows Mental Health Policy Institute, another acronym, Andy Keller, likes to talk about that, 20, 30 years ago, we used to whisper when we said cancer, but now we say cancer, and people are not afraid to say they have a cancer diagnosis, and they're not afraid to talk about their treatment. And so we want to have that same effect with mental health, that we're not going to get people to get better with their mental health until we can talk about it in a stigma-free environment. So I really think that a lot of the reasons for why we still don't have the correct resources has to do with that. And this is where NAMI is really such an important resource, because you're out there every day helping beat back this stigma and advocate for those who have mental health difficulties and need support and assistance. But when you look at the breakdown for youth, and the number one leading cause of death for youth in both the ages 10 to 14 and 15 to 24 is accidents. So that is the most common reason for young people die in America. But the second leading cause of death for both the 10 to 14-year-old and 15 to 24-year-olds is suicide. So 596 youth lost their lives last year related to suicide in that 10 to 14-year-old age. And then 15 to 24, it was 6,200. And then when you look at the third leading cause of death, it's cancer. And I am in a big medical center here down in Houston, and I can tell you, we spend a lot of very important dollars on research, on prevention related to children's cancer. And it is again, important, and we don't want to stop doing that. But I'm looking at Deanna when I'm saying this, actually, so we're on my screen, but we don't seem to have that same passion and for advocacy for mental health. In that 15 to 24-year-old range, the third leading cause of death is homicide. So again, we spend a lot of time and energy with these other sort of aspects of illness, as well as societal, challenges that we don't do with things like suicide, or just helping with mental health before it gets to the point where a person feels like the only option they may have is to take their own lives because of their desperation. So we need to do something different. And I'm here to say that that's one of the things that both TChat and Cpan can potentially do, is help make interventions in a more timely fashion to keep us from getting to that point where we're seeing this continued rise. Now, I'm not saying it's going to turn it around tomorrow, but I think with a concerted effort, both Cpan and TChat can help start to turn these numbers around for Texas youth and their families. So I told you that we were going to talk about the allocation of child psychiatrists in the state of Texas. This is from the American Academy of Child Psychiatrists. Texas is a sea of red. Now, actually, to be fair, the whole United States is a little bit of a sea of red when it comes to this. In this case, red means there's not enough child psychiatrists. But even within when you look at this map of Texas, for example, we're very unevenly distributed. And so there's lots of counties in Texas that have no child psychiatrists. So people have to drive 3-4 hours to see a child psychiatrist, which, again, where I am in Houston, I do have people sometimes drive all the way from New Orleans, San Antonio, down the valley to come see us. And it's really something that we want to try to change. And that's what the state legislature in Senate Bill 11 was really designed to do. Because as you said, all those different approaches I said will take time to work through, but Cpan and TChat in particular can start working right away to help youth and families, get care in a more timely fashion that's patient-centered and, comports with families' values. So this map basically tells us why the Senate Bill 11 happened. There's not enough. And I know this is focused on child psychiatry, and we definitely understand that there are more types of mental health providers that are desperately needed and not just child psychiatrists. Maybe that'll be the next push for the next bill, but this is where we're kind of at right now and what the bill funded. So one of the things that we understand is that even though we need more child psychiatrists, as I said, we understand that it's not only a child psychiatrist's abilities, we need everybody's abilities, all hands on deck. So we have asked for pediatricians, family docs, physician assistants, nurse practitioners to put on their cape and their mask and help save the day. So we understand that in order to do that, the primary care doctors need to shift some tasks, and they need to work more in promotion of mental wellness, also work on early identification and screening so we don't get to that point of desperation. And then actually we need those primary care physicians to do targeted first line care in their own office and not send a family and a kid off to a specialist, because there are things that they can do in office. And that's what we're really targeting when it comes to Cpan. And this really is this idea of a collaborative care model. So primary care providers really are the heroes of the story. And I like to say that the Child Psychiatry Cpan network is the Robin to their Batman. We're there to be that support, but what they're going to do is actually meet the families in office and help them, and we help the pediatrician and the family doc do that work. So we know that does mean that those primary care physicians will need to build some new skills that they weren't able to get in their residency, and maybe they're not doing right now in their own training, in their own practices. So we want to have this collaborative and consultative relationship that will really help them learn some additional skills and have some additional knowledge, and that we will help support them and be that tech support for them when they're working with kids and families in office. And I'm not saying this as a child psychiatrist. I'm saying this as the American Academy of Pediatrics. This is something that they have recognized for over a decade, that primary care physicians, and actually my dad's a family physician, and it's the same thing within family practice. They recognize that we need to help train pediatricians and family docs to manage this in office, and where we've so far not been successful in doing that. And that's one of the reasons why we desperately need a network like Cpan. So as I said, why do we do this in primary care? Because the burden of disorders is great, because we know that physical health and mental health problems can be interwoven. We know that there's a treatment gap, as I just said. We know that for many families, there's still stigma about going and seeing a child psychiatrist. I know plenty of primary care physicians will say, well, I made that referral, but the family never came and saw the specialist. And so because the families have a trusting relationship with the primary care doctor, we want to try to support that and allow for the primary care physician to do things in office with a family that maybe will avert, like I said, a need for going and seeing the specialist. And so we do know that collaborative care models work, and that's why we want to move into this model here in Texas. And because the primary care physicians, as I said, have had lack of training, they don't know how to diagnose, they don't know what are the appropriate treatments sometimes. There's definitely inadequate reimbursement for them doing some of this work. And we also know that we don't want to say that everything is about mental health, because obviously ACEs and other psychosocial stressors are really impactful. So we want to help separate those things out and really help a primary care physician know what it is that they can do. And we also know people have mental health attitudes and or stigma that are not always useful. And we're hoping that Cpan can kind of help break down those barriers for those primary care physicians and maybe for the kids and families that they're treating. So when you look at this, this is a very busy slide, and basically I'm going to help you. This is what we're talking about right here. Cpan is a consultative network for primary care physicians, and it's to help them in their settings for youth that have mild to moderate mental health problems. I went to school for a long time to be a child psychiatrist. I am not at all saying that I can turn a pediatrician into a child psychiatrist, nor would they want to become a child psychiatrist. What I'm saying is that they can get a consultation with a child psychiatrist, and for mild to moderate problems, we will coach them and help them every step of the way, so that they will provide an evidence-based, family-preferred form of treatment that will hopefully be successful, and again, avert that potentially a need for always an escalation to a referral. So this is what we're asking for the primary care physicians to do when it comes to Cpan. So what is Cpan? Maybe you're asking there, and you've been going, well, she hasn't actually said what Cpan is yet. Well, here we go. Cpan is a child psychiatry access network. Now, we understand that this is a little misleading, but this is what got written into the legislature, so we can't change it. So who's getting access to Cpan? It is not direct family service. Who's getting access is the primary care physician. So when a family comes into a primary care physician's office with a mental health concern, and the primary care physician is not sure about what to do, then they can call and speak to our teams across Texas, get a real-time consultation while the patient is in office, and they can call us as many times as they like. So every time the child and the family comes in, they could call us back, and we could help guide them and the family about what are the steps to take for those mild to moderate problems. We are modeled very closely after a long-standing program called MCPAP in Massachusetts. So here's a website here. You can go and look at a much more mature and robust website that we hope to grow up to be for Texas Cpan in the very near future. But this program in Massachusetts is not a flash in the pan. They've been running for over 17 years very successfully. So we are not doing something in Texas that's all experimental. We're doing something that's very much has a proven track record. There's actually 37 other states in the United States that have some version of what we're doing in Texas. So you could say that Texas is a little late to the game, but you could also just be thankful that they got in the game. So we're glad to be going, but I want people to be really clear that nothing that we're doing here is new or experimental. It's been proven to be effective to providing an evidence-based care that patients and families are accepting of their values. So how do I know this? Well, there has been some research looking into this, and there's 2 articles here on this slide that you can go, if you wanted to go and look at these, you may or may not, but if you did, here they are. I'm going to give you on the right the answers to what sort of these studies found. And so this first one is asking the primary care physician, what did you think you got out of using the MCPAP network? And what you can see here is that they did believe that they had an enhanced ability to deliver mental health care that was consistent with family preferences. And to me, that's so important, particularly when I'm talking to folks with NAMI, is that this is not, we're shoving something down your throat and you got to listen to us because we're an expert. It's we're going to partner with you, and this is what the family is preferring, and we're coming up with a plan that works. And then what we also know, which is what we want, remember I said that family physicians and pediatricians feel their skills are deficient? Well, the PCPs say that by having this consultation team that they can call and talk to, they actually do learn things. So old dogs can learn new tricks. And they do use that knowledge that they gained in another care to help a future care. So that's exactly what we're talking about, is that they become more competent themselves, and maybe they start to be able to manage things that are a little more complicated than they were when they started with Cpan initially. We do have some evidence, though, that some PCPs never call. And so one of the things that in Texas we're going to really try to figure out is how do we help support those primary care physicians who never call us? Because I go back to that slide that we had a few slides ago that's about that there's not enough child psychiatrists. It's simply not enough anymore for a primary care physician just to say, I'm going to refer this. Because you might have a family wait 3 months, 6 months or longer, and that's too long. And so we really want to figure out what can we do to help those primary care physicians who have reluctance to pick up the phone and call us. So that's why I'm telling you, potentially as parents and family members, tell people about it, have their primary, have families say, well, I know there's this network, maybe you can call Cpan and they can maybe help us together. So that's why we want to tell families about it, not because families can call the number, but because they can potentially encourage their primary care physician to make that call and to make that connection. That second paper that you show here, that I show here, not you, is an article about asking actually parents and families, what did you think about your primary care physician using MCPAP? And basically what they found was very, I think, reassuring to primary care physicians, is that actually parents were highly satisfied with the fact that a family physician cared enough to actually speak to an expert about what to do when they didn't know how to do something. So I think sometimes doctors, unfortunately, get in this bind where we think we're supposed to always be expert about everything. And that's a little bit impossible. But what you can do is say, you know what, let's call Cpan, let's talk. Let's see what might be the next best step based on what's going on. And so what it actually did was strengthen those relationships with the primary care physician, because they felt even more trust knowing that the primary care physician cared enough to actually reach out and get some expert advice about what to do. So these are just two articles that really speak to this idea, but collaborative care models have time and time again shown to be effective in helping manage those mild to moderate mental health challenges that we can maybe avert from becoming crises. So as I showed you earlier, this is the slide of the network across Texas. Each of the HRIs, remember health-related institutions, have a region of Texas that they're responsible for. We have been live since May 18th. And so this phone number that you see here is for that primary care physician to call on Monday through Friday. Actually, let me just stay on this slide and then I'll skip the other two slides in a minute. So the primary care physicians can call this 1-800 number Monday through Friday, 8 to 5. They can speak to any of the team that they need to and get some assistance in office that day when a family is there. This is for all pediatricians, family docs, nurse practitioner, primary physician assistants. Any and all are being currently right now invited to enroll in Cpan. It is no cost to the primary care physician and no cost ever to families. The state is paying for this program out of general revenue, not in, medical dollars. So this is general revenue dollars. So this is not a service that anybody is being charged for receiving. When we ask for primary care physicians to enroll, we ask them for a little bit of their information so that if and when we call them back, we can make sure to keep parents and kids' data secure and not hand it out to the wrong people. So we do ask for a little bit of enrollment, but it's pretty painless and easy to do. And we want to encourage all primary care physicians to get enrolled in the state of Texas. Now we know for a state as small as Massachusetts, it took over 2 years for them to enroll their practices. When I actually asked somebody to figure out how many Massachusetts fit in Texas, I think somebody gave me the answer that it's like 11. So we're basically starting 11 sizes of Massachusetts Cpan, but we're still trying to go on that ambitious goal of hopefully having all primary care physicians enrolled within the first 18 to 24 months of going live. So a primary care physician can call and enroll before their call, or they can just call us. And so what we're going to do in addition to that call is that we're also going to provide offline services to help educate and further their knowledge and skills. So we're going to do presentations, seminars. We're going to give them algorithms that we're going to share on that state website that I was talking about. So we're going to have a lot of different ways that we're going to try to connect and support the primary care physicians and what they're doing. We like to say that the Cpan service is three services with one team and one phone call. So when that primary care doctor calls us, they can get resource and referral assistance. So maybe the family is pretty certain that they know what's going on. The PCP is as well, but they just don't know where to send. Well, they can call our team and our team will help find hopefully a couple of programs if possible that are warm handoffs, not dead ends, not just a list to nowhere, which I know is very infuriating. We can also help with behavioral planning for youth in office. So for some of those mild to moderate problems where perhaps a medication is not indicated, but the pediatrician can provide some guidance, we can give that pediatrician step-by-step guidance about how to do that with the family. And then finally, that educational consultation with the real time with a child psychiatrist who is board certified, like somebody like myself. So we have a state metric that if the pediatrician calls and wants to speak to a child psychiatrist, they will get a child psychiatrist on the phone within 30 minutes. So we're really clear when we looked at other states across the union, what made some of them more successful was really having a quick access to really speaking to that child psychiatrist if that was what is needed. So we made sure that we had that sort of built into our process. So across the state, the primary care doctor calls and who they want to speak to is a child psychiatrist, then they will get that call back within 30 minutes. So if the family is in office, we can help while the family is in office before they leave. Okay. So we would certainly, love for you to join Facebook or LinkedIn. Typically, I don't tell people to look at your phone while I'm presenting, but this time I'm like, sure, go ahead. Put in the Cpan Facebook, put in the LinkedIn. We are going to, our Facebook page periodically twice a week basically puts out new information. So it's just another source for you to learn about tidbits about mental health. If there's a presentation going on, we put that on the Facebook page. So it's just another opportunity for you to learn about things that are going on in the state of Texas as it relates to mental health. And then if you thought this talk was too long and you wish Dr. Williams would just shut up, she said she's talked way too long. We actually made a 3-minute version of what I just said, me and Dr. Tran. So you can look down at this YouTube. It's also on the Consortium website, I think, but it's 3-minute version of what I just said in the last, 25 minutes. You can decide which one's better, but don't tell me. And then finally, I know I'm kind of running down with time, but I'm almost done, I promise. This is the Texas Child Health Access through Telemedicine. Say that 5 times fast, particularly at 8 o'clock at night. You may struggle, I do. But what we understand about where are kids during the day? Well, they're at school. Where are parents during the day? Well, they're often at work. What is anybody doing during the pandemic? I don't know. Certainly the pandemic scrambled a lot of plans. We also know that there are different needs when it comes to rural schools versus urban schools, when it comes to bandwidth and being able to access. And we also know there's not a lot of child psychiatrists when you get out into those rural areas. So we really think that TCHAT can be a solution for care that is timely, evidence-informed, patient-centered, and is a partnership with those primary care physicians, the schools, and the local care teams. So what the TCHAT service provides is a mental health assessment with either a therapist or a child psychiatrist or both, depending on what the issue is for the young person, and then short-term care, so up to 4 appointments after that initial assessment. This is all paid for by the state, so the family and the schools are never charged for these services. So obviously we would like to be in lots of school districts. We're not in every school district in the Texas, so let me be clear there. But we are working to steadily expand our reach and be in more and more ISDs. So again, I would really encourage you, if you know of some school districts that maybe are looking for additional mental health services and they might be open to talking with us, please feel free to let us know, because we're out there talking with the TEA, their educational support centers. We're really working to partner with people. The worst thing we could do is reinvent a wheel. So we don't want to go and be in a place where they already have good services. We want to go and be in places where they're lacking services and they really need a program like T-Chat. So this allows for families to get an urgent appointment without necessarily sometimes even the kid having to leave campus. Or in this case, because of the pandemic, we've been doing a lot of this telehealth actually in families' homes. So we didn't stop T-Chat just because schools had to close down. We just sort of jigged and jagged and did the work through telemedicine in families' homes. So we'll probably have a blend or a hybrid of some of the work being done on campus, particularly for those rural areas where maybe broadband in families' homes is not always good. They may need to come to campus to get that appointment. But we also know that sometimes families really still enjoy the flexibility of doing an in-home appointment. So we'll probably continue to provide some hybrid even after COVID of doing things on campus as well as doing things in families' homes. So right now you can see this map where T-Chat services are currently located. We are going to have services up in North Texas. UNT is sort of in charge of that region, and they're working steadily on some school contracts to get services up and running there. Again, our goal over time is to be spread out into as many ISDs and schools as we possibly can in the entire state. And as of October, this actually is changed since October. We're partnered already with 96 ISDs across the state of Texas. We've had over 300 referrals and we're rising fast. And as I said, our goal is to partner with a number of organizations to not reinvent the wheel, so that we can really make sure that we're providing targeted interventions for kids who really are otherwise not able to get services. So our big goal with T-Chat is to coordinate and collaborate. So that's kind of what we're doing so far with T-Chat. And I said I was almost done, and I promise, yes, I am done. So thank you very much. And again, the one thing I just want to keep reminding everybody is this phone number is for primary care physicians to call, not a direct family service. But we really would say encourage primary care physicians to call by families being advocating for it and saying, hey, I know there's this Cpan program that you could call. Why don't you, Dr. So-and-so, give that team a call? I know that they could potentially help. So thank you very much for your time, and I'm happy to answer any questions.
Sorry, I just put myself on mute. We did have a question in the chat. And the question is, if a primary care physician doesn't know about Cpan or is hesitant to take advantage of this resource, how do you recommend parents advocate for their children and get access to that expertise?
Well, I really think that, you know, all the pediatricians and family docs I know, like again, my dad, who's been, he just actually retired from family practice this January, right as the pandemic was hitting. He was desperate to have a child psychiatrist or even a psychiatrist call him back. So I think you're going to find that if there is, we're working with TPS, we're working with the Texas Family Practice Association to get the word out. But I really think that if a family just says, you know, Dr. Carpenter, I know there's this service called Cpan. I bet if we look it up, you know, you could get the number, and I know they're available. I know that primary care doctors, they want to help. So if they are not aware of it and then they just become aware, then I think that you can kind of, the family can help get them over the hump and get them to call. Again, they don't have to listen to us. They don't have to follow our advice if they don't want to, and neither does the family for that matter. You know, whatever we sort of consult and say with the primary care physician, they still go back to the family and discuss. So it may be, so it's still a fundamentally decision of what to do or not to do, you know, based on family choice and preference. So I would really hope that your primary care physician, who, if they didn't know about it, once they learn, would be welcoming of making that phone call.
Yeah, personally, I love that, because I don't know if you saw my 7-year-old, but she, you know, we had struggled a year or two ago with knowing where to go. And when we went to the primary care physician, it was, oh, go see this play therapist and see this person. and she wasn't severe enough to go see anyone, you know, that our insurance would cover or whatever, but yeah.
Yeah.
I'm seeing if there are any more questions. I just want to encourage you guys, if y'all have a question, to put it in the chat. I'm not sure if anyone can unmute themselves, but we can see your chat if you have questions. Do you know what schools you are in the North Texas area? What schools do you cover?
So the UT Southwestern is one of the hubs, and then UNT, University of North Texas, is the other. So I guess it will kind of a little bit depend on what part of North Texas you're talking about. We are working on sort of an interactive map that would be up and available for people. It's not there just yet. So again, the UT Southwestern team has a large number of ISDs that they are involved with. I actually can't think of all of their lists. The UNT program has not started their TChat services yet. They're planning to go live in January. So you'll be on the lookout for that UNT team and the ISDs that they're going to serve. But we do hope that we can have that sort of information, you know, on the consortium website for people to see.
And we have a small enough number of people that I am going to allow people to unmute themselves so we can have a discussion. Some people may feel that it's a little bit easier to verbally ask the question. So if you do want to verbally ask a question, you can now unmute yourself in order to ask it versus trying to type it in the chat box.
Gary?
Well, I have a question. Do the children who are in the process of being diagnosed, do they network, or do the families network around the state of Texas? And in your opinion, doctor, would that be a good thing?
I always think it's a good thing for people to network. We are talking about how to actually coordinate and collaborate with sort of partners such as NAMI. We are talking about actually how to have both families and peers with lived experiences participate with the Texas Child Mental Health Care Consortium. So I definitely think that that is something that we would encourage and recognize as a powerful way to move forward.
Thank
you. Do you have your program is in Spanish?
The Cpan and TChat? So TChat, absolutely. We will certainly work with a young person regardless of their language. All of the TChat teams will have interpreters. So definitely language should never be a barrier for getting a service.
Great, thank you.
Mm-hmm.
I have a question about your partnerships with NAMIs. Have you been encouraged, or do you know about ending the silence, and have you been partnering with any NAMIs to include this information in the Ending the Silence program for staff and parents?
Not just yet. We've been working with our own local NAMI because we have at least at Baylor, we have a system of care grant for youth with bipolar and first episode psychosis. So the local NAMI chapter is definitely a partner with our team. And so we've been working with them, but we haven't yet done things on the statewide level. So we would be certainly interested in that work, in that partnership.
Yeah, I'd be fascinated. I would love to give this information to parents and staff when I speak to them, because I know so often we are always looking for more. How else can we help our children, our students? Someone's asking, how can other mental health agencies get involved?
Well, the number one thing we need is that we're actually working on a statewide referral network. We're using a platform called WellNeti, and it's sort of a combination of Aunt Bertha and crowdsourcing. So what we're going to be doing is working with all the HRR hubs. So wherever you are, if, you know, particularly since I'm talking North Texas, there's a good chance that your Cpan hub is Dr. Podowitz's team at UNT or the UT Southwestern team. So letting them know about your resources, because we're uploading resources and into this platform called WellNeti. Eventually the WellNeti platform may be something that families can search themselves. But what happens with WellNeti is that as we put things in, we try to make sure that the way the WellNeti platform works is to keep things up to date and accurate. So, because you know that a lot of times what happens is you spend a lot of money to create like a trifold, and by the time you get the trifold out, half the services aren't available anymore. So what WellNeti is sort of designed to try to do is keep a running list of what's actually still active, what's not active, and then also crowdsource. So if I say, hey, I'm looking for services for youth with autism in blank county, and let's say the first search comes up with nothing, well, all those other mental health providers that, such as yourself, who are on that network of WellNeti, you see that come across your email and go, wait a second, I know of a resource, and you type it in, and then that team member gets to know there's a resource available. So what we're really hoping to do is gather and collect as many teams and resources that we can, so that everybody is on that network and you can crowdsource when initially a search answer comes up empty. So that's the best way I can think for teams to immediately partner, is that work that we're going to do. And then also with TChat, because TChat is just for appointments, and then we have to help the families move along, we definitely will need to find partnerships in our regions of care providers who can see the young people after those 4 sessions of TChat are done, but the young person still needs a service.
Yeah, they've continued their question to ask, do the resources need to be psychiatrists, or can the clinicians be LPCs, LCSWs, etc.?
Yes, absolutely. Like I said, there's been a number of statements around that the bill was sort of physician-centric, and the answer is yes, it was. Again, as somebody who's been working in mental health for a long time, I always work in teams. And so I definitely would say we want to get the ABAs, the BCBAs, the LPCs, the LMFTs, the LCSDs, like all, LCDCs, like everybody that provides mental health services, we're really hoping to collaborate with and build that steady network. And so it's not going to be something that, again, is done tomorrow, but we do want to kind of work on it and get that there. So that's definitely the case, that we know that there's actually, for kids, there's a lot of evidence-based treatments that are not about things that a child psychiatrist does. So we definitely I don't want you to leave the impression that it was just child psychiatry.
Okay.
Well, as a parent and as someone who was a teacher and as someone who does our youth programs, this is really great and fascinating information. So I just want to say personally, thank you so much. And I'm going to hand it off to Dr. Trenton and have her unmute and kind of sign us off, because we're getting down to the hour.
Thank you so much.